It says I'm recording now, so I am going to finish up chapter 13. So the reason I separated this, I realized there's only a page and a half left, but it's about specimen care and it's totally separate and it's very important. So I really wanted you to focus on specimen care and understand all the details of it. So I will share my screen with you. You will see that this slideshow is also a little different than my usual, so it looks a little boring, but I really wanted you to catch the important details between fresh, permanent, and frozen specimens. There's different ways to send them, so that's what I'm going to talk about today. So again, chapter 13, I try to always point out page numbers for you, and I kind of added some stuff onto my slideshows of page numbers and things like that. So it will make it easier for you to learn with this new hybrid program that we're doing. So this says lab studies and specimen care, because I already talked about most of the lab studies, but it hits it a little bit. So I'm starting at 390 at the bottom of the page where it says laboratory studies. So I really don't need to read through this part because all of your values are in this chart, and everything you need to know about lab studies you've actually already learned in previous chapters. So I'm going to take a moment to look at urinalysis on 391. So look in italics and see where it says clean catch. So a clean catch sample involves cleaning the urinary meatus prior to voiding or urinating and catching the sample midstream into a sterile collection device. So I want you to be familiar with clean catch, but that's really the only detail I want you to hit. Instead, go down to the next paragraph. Still under urinalysis, very bottom of the page, see where it says many employers require drug screening and urine tests. So just as a reminder, I did the same thing with the last time I taught this course, a reminder for you that you will have a drug screen before you go to externship. So hopefully you are prepared for that. And know in general that hospitals are always going to do drug screenings for pre-employment. What I want to add is anytime any type of an accident happens, which is very common in hospitals, you will get sent to do a drug test. So get stuck with a needle. They're not just sending you to the ER to test your blood and the patient's blood to check on your safety. They are also going to make you do a drug test to make sure that you weren't under the influence of anything when that accident happened. So that's the company, covering themselves, but it's also making sure that we have people taking care of patients that are not under the influence of anything, because we want to provide good patient care. So just a reminder for you on that urinalysis section that you will be having another drug screening if you are eligible to go out to externship. Okay, now to the lecture. Not much to add on urinalysis for scrub techs. So, all right, your bacteria test. So you have something that's infected in surgery and we need to do a culture and sensitivity. So this slide is in super bold because it's very important and I want you to know it. You will use these culture swabs often, and this is just one example, there's other kinds, but you'll use culture swabs often because they want to test that tissue. If it looks a little different, they want to make sure there's no infection there. They really want to find out exactly what bacteria is there. So look in your book, page 391, under your bacteriological tests. That's where I am. So tissue or fluid can be tested this way. So tissue or fluid, they're worried about it being infected. Most tissue you can tell by looking at it, right? Pus tends to be yellow. So if something looks like that, they're going to say, give me a culture swab. So they're going to culture it so that the pathogen can be identified and treated. So the specific pathogen. So the two tests are going to be culture and sensitivity, which is what I'm talking about right now, and gram stain, which I will talk about in a moment. So with this culture and sensitivity, the sensitivity part, let me talk about that. They're basically going to report back after testing this with sensitivities so that the best antibiotic can be given. So I have to do my little spiel about antibiotics. If you're somebody that has a medicine cabinet full of old antibiotics, that's incorrect. Go ahead and take those out and throw them in the trash, because if you're not finishing your full antibiotic cycle, you are defeating the purpose of starting that antibiotic. As you know, you start taking the antibiotic, you start feeling better, and you think, I don't need to finish these last couple pills. In reality, that bacteria is still there. Even though you're starting to feel better, there still might be a few bacteria there. So you need to finish that antibiotic so it kills the whole thing off. And then that brings me to the next part, the specific antibiotic, right? So if you think, I have a sinus infection and I have, my dad's leftover antibiotics, why don't I just take those? No, they want to test exactly and give you an antibiotic for exactly that bacteria. So it's actually what's awesome about surgery is we can swab right there because we're looking at it and give the correct antibiotic that's actually going to solve the issue, rather than when we have things like a sinus infection, we don't know exactly what that bacteria is. So in surgery, we are going to do this culture and sensitivity to find exactly what bacteria it is, and then we can give the best antibiotic that's going to treat that bacteria. Okay, so let's look at culture and sensitivity. So CNS, culture and sensitivity, is performed to determine the exact organism, as I said. Know that it'll be about a 24-hour incubation process. So that sensitivity identifies the antibiotics that are effective against that pathogen and requires an additional 24 hours. If you look right under that, it starts talking about our culture swabs that I have pictured on your slideshow, and I have them right here with me also. So usually red and blue, but you can read on the back of the package to see whether it's aerobe or anaerobe. Some culture swabs are both. Let's say that one more time. Some culture swabs can test for both aerobe and anaerobe. This is the way I am used to seeing it, and most hospitals have it, and our lab has it. So one aerobe, one anaerobic. So let's look at that part. You are doing a surgery, you cut in, you see something infected. The surgeon says, give me a culture swab. So you will open this up. They will swab the infected tissue. You're going to take the cap off. They're going to drop it in the tube. You're going to close it as tight as you can. You're going to pass that off to your circulator as a specimen. You need to know why you have aerobe and anaerobe, though. Why do we have two? Let's go through that part of it. So find in your book at the bottom of 391 where it says aerobic and anaerobic studies may be ordered, each requiring its own specialized container. That's what I went over. Culture should be sent immediately to the lab to preserve the microbial population. So here's where you're going to make a note, or you can read this slide. Aerobic requires oxygen to survive. So these types of bacteria pathogens are superficial. So you might cut into a wound and superficial, you're going to see these aerobic. So that will be requiring oxygen to survive. So they have oxygen they can reach. Anaerobic, these are found in deep wounds, abscessed wounds, encapsulated pockets of pus, things like that. We think we are going to call them anaerobic because they are deep in the wounds, they've not been exposed to any oxygen. So that is the difference between the two words. Make sure you know the difference between aerobic and anaerobic and where you tend to find these. So again, anaerobic found in deeper wounds or abscesses. So anaerobic, the organisms are going to die quickly when they're exposed to air. Okay, so that is my culture swabs. Very common to do in the operating room. Make sure you're familiar with what culture swabs are. Okay, that brings me to gram staining, still talking about bacteria, right? So gram stain on page 392 up at the top of the page. So again, I don't want you to pay attention to the year so much, but it was invented in 1844, so we've been doing this for a long time. It's going to help us identify the bacteria. That's what I want you to learn from this. They want to identify the bacteria. Now, the way they do this is exposing it to different stains. So you can go ahead and highlight your stain, crystal violet. So by exposure to the stain crystal violet and iodine, they'll rinse it with alcohol, but they're going to stain it again. So I don't want you to worry about the process. You're not going to be doing the gram staining. I want you to know the stain, crystal violet. They will be staining this bacteria. After that, now it will tell you how this test, this dye, is going to help us tell the difference between different types of bacteria, especially gram negative and gram positive. So notice again, it says crystal violet. That violet looks almost blue. So you'll hear in different textbooks the word blue and purple thrown around. Like in my textbook I learned with, it said purple dye. This one says blue dye. So just keep that in mind, still the same dye. That's called crystal violet. So one more time, bacteria that retains the blue dye is going to be gram positive. So you see on your slideshow, gram positive has a thick cell wall and retains that dye. So the thicker cell wall allows it to retain that crystal violet dye, so it's going to be bright blue or purplish. So again, the bacteria that retain the dye are gram positive, and those that fade to pink don't retain the dye, if you need to add that in, are gram negative. So gram negative has a thinner layer, so it's not going to retain that dye. So that's why it has that faded pink color. It was exposed to the dye, but it did not retain it well. So that's how they tell the difference when they're doing this gram staining between gram negative and gram positive bacteria. So this identification can help the physician determine the course of treatment. So when they culture and sensitivity results are available, they can revise the treatment from there. So the surgeon can decide what to do, what they want to, what antibiotic they want to give based on the gram positive or gram negative staining. Okay, so those were the two hardest part, by the way, learning anaerobe, aerobe, and the gram staining positive and negative. So that's why it's all big and bold on the slideshow for you to make it a little bit easier for you to understand. Okay, so those are our tests. Now we can go into surgical specimens. So surgical specimens, look at your first sentence. You need to know two different terms, histology and cytology. So the excised tissue is going to be histology. We're going to study that tissue. Aspirated fluid would be cytology. So we're going to study that fluid. We're going to do lots of biopsies, and there's lots of different ways to take it. I've got some examples with me, but I'll leave them in the classroom so you can put your hands on them if that helps you understand the different ways to take biopsies. So under types of surgical specimens, I can read what's in your book to you, and then I will explain what's on my slideshow. So again, in bright green on page 392, types of surgical specimens, that's where I am. So tissue biopsies, specimens can be obtained in lots of different ways. So percutaneous or core needle biopsies, fluid washings, brush samplings, incisional and excisional, and then it says including frozen sections. So that section is worded a little bit confusingly, so I broke it down for you myself so you don't have any confusion on what is what. So you will see the only thing not in this section on your page 392 to 393 are the washings, and I'll explain that. So let's talk about specimens after looking at that, in my opinion, confusing paragraph, and let's translate it into what we need to know. So incisional biopsies, you have lots of different options. I already gave you one, so culture swab. So we've made an incision, but we're not excising a piece of tissue, so we're just gonna swab from that incision. So culture tube, that's one. Another one is needle biopsy that you see at the top of your page. There's lots of different kinds of needle biopsies. I'll just show you one. So this is a device where you can stick the needle in, and when you pull the top, it basically allows a small chunk of tissue to come out with that needle without damaging anything else. So it's giving us a needle biopsy, very small piece of tissue. So needle biopsy cultures, and then what your book doesn't really say, a piece of a mass. So there could be a tumor and it's so big they don't want to take the whole thing yet. They just want to take a little part of it, send it to pathology to figure out what it is. Those are all types of incisional biopsies. After that, excisional, this one is nice and simple in your book. It describes it perfectly, just the removal of the entire mass or lesion. So we're not leaving anything else, we're excising all of it. That one's nice and easy. And then I added needle aspiration, AKA centesis. So all of your synthesis needle aspiration falls under synthesis. So at the very bottom of 392, all the way to pericardiocentesis and 393. All of those are needle aspiration cases. That's why I want you to have them under. So it says synthesis and fluid analysis. That is correct. I want you to put needle aspiration next to it. Makes it simpler. Okay, so I have classified everything. Again, the only one I didn't classify under these options is the washings, and that's because it's a little different. We can't really call it incisional because there's no tissue on there. We sometimes don't even make an incision to get the washings. So it's hard to call that one incisional, so it doesn't really fall under any of these categories. But you just need to know what washing and brush specimens are. So I don't want you to worry about categorizing them. I wanted you to understand the difference between incisional and excisional biopsy. That's the main thing I wanted you to get from this. After that, I want you to understand what synthesis means. And then your book gives you lots of options for examples for synthesis. Okay, so now that we hopefully understand the methods to get out the specimen, now we can start looking back at the book. So again, right under the green, I read that paragraph to you, reworded it, and we're gonna move on from there. So let's talk about the different ways to send specimens, right? So before I get to what's on your screen, your permanent and fixed, let's look at 392, top of the page, right side. So stay on the right side of the page. So looking at needle biopsy, I just showed you an example of that one. So you can take a piece of tissue out with the needle. Now let's stop at washing and breast specimens. So pelvic washings are done a lot during hysterectomies. I want you to know that one. Pelvic washings are done during hysterectomies. So any other pelvic surgery by irrigation of the pelvic cavity, they can do pelvic washings that way. There's different ways to do it. Every case you have suction tubing, correct? So you could just suck up your fluid and they can catch it in a container that attaches to the suction tubing. So that's one way to do it. Another way is your big asepto syringe. They can just get the fluid out of the abdomen, put it in a specimen cup, and send it for pelvic washings. So there's different ways to actually take that specimen, but very common in surgery. And I want you to match up pelvic washings with hysterectomies especially. After that, look at your second bullet point. Your surgeon may also insert a flexible wire with a bronchoscope. This will have a little brush on it, and you get to brush out the specimen into your specimen cup. And I actually have a cytology brush. Well, here's an example of a cytology brush. I want to stop and point out that a bronchoscopy, checking out the bronch, looking with a scope, that's going through the mouth, correct? Into your bronch, so your airway. None of that is sterile. So this is a non-sterile procedure. You won't be wearing sterile gloves. You'll be wearing different like exam gloves, and your surgeon won't be sterile either. So now that you know that part, with any type of brushings, you'll have something like this. So it has all this excess that you have to take care of. So when they do a brushing, you kind of feed this down into the tube, and then the surgeon gets it back to you. And once you have it on the end of your brush, you can simply rinse it off into that specimen cup, and then you're ready to take the next specimen. So bronchoscopes, gastroscopes, colonoscopes, any of our scoping that we do in a non-sterile fashion, they have a way to take a biopsy through them or to take a brush sample through them. So I just wanted to point that out for you so you know that they will be taking specimen on some of those usual diagnostic cases. Okay, so after your bronchoscope, again, these were just two examples of washings and brush specimens. So after that, I want to move on to our incisional and excisional biopsies, and then I can address our permanent and fixed specimens here. So know the difference between the two. I already gave it to you. Incisional is removal of portion, excisional is removing the entire mass. Both forms of tissue can be processed in permanent or frozen sections. Here's where you're going to add, or fresh. Also be sent as fresh. So usually you're gonna have the options of, here it is, fresh, frozen, or permanent. Another word for permanent is gonna be fixed, and I will explain why that is. But you need to know that there's 3 options anytime you send a specimen. So I would make some notes on the side if you need to about just specimens. So again, you're going to be asking your surgeon how they want it sent, and you need to know the options at least. So one more time, permanent, frozen, and you're adding fresh. Okay, so now I will break it down for you so you understand it. I'm going to start with permanent sections. So again, I'm under incisional and excisional biopsy, and I'm starting on the paragraph that starts with permanent sections. Permanent sections are placed in a preservative such as formalin. So you need to know that they're going to put it in formalin and then what the formalin is going to do. So the reason they have an alternate term of fixed is because that's what the formalin does. It fixes it into place, makes it permanent. So then the pathologist can cut it into thin slices to then view it under the microscope. You don't need to worry about what they're doing in pathology as much. It might help you understand the process, but I need you to know what to do at the field. So again, with permanent specimens, you're going to be using formalin. So permanent specimens are fixed in formalin. Permanent specimens always fixed in formalin. So now you need to know the never ever in formalin. So kidney stones, never ever in formalin. This is because it's going to disintegrate the stone and then you'll just have liquid, unfortunately, at pathology. So it will dissolve that stone and we won't be able to test it in pathology. So if you are told to do a permanent specimen on a kidney stone, that is a time where you could say, that is incorrect. We are not going to put this specimen into formalin. So kidney stones and fresh frozen sections must never be placed in formalin. Makes it easy for you. Permanent is fixed in formalin. The rest of them don't get formalin. Makes it a little easier for you. Okay, so that was permanent sections. Permanent sections. After that, we'll go to fresh and frozen section. Your book focuses on frozen sections, and they focus on that for a very good reason. So I'm going to talk about frozen first. So frozen sections are performed to provide immediate diagnosis. So usually cancer cases, that's where we're going to want a frozen section. They're going to do this to determine if it's necessary to excise more tissue. So they're looking for a yes, it's cancer, or no, it's not cancer. So again, they're going to use medical terms. So they will get a call back from pathology and they will either say it's benign or it is malignant. So if it's malignant, they might take more pieces and get the rest of that malignant tumor out of there. If it's benign, they might leave it because it's benign, it's not cancerous. But they will base their decisions off of this frozen section. Okay, so again, to determine if it's necessary to excise more tissue, might be one reason to do a frozen. And then to initiate post-operative therapy as soon as possible. So sometimes they just want to know whether it's cancerous or not. So then as soon as they wake up from surgery, if it's a well-involved cancer that has moved along and progressed, they can start that therapy as soon as possible. That's going to help the patient have better chances of recovery. So anything to do with frozen specimens, that is somebody's cancer treatment you're holding in your hand. So you do not want to take that lightly. You want to take it very seriously. You want to take all specimens very seriously, but to me, when it's a frozen specimen and we're waiting to find out whether it's malignant or benign, I take that even more seriously and I take extra special care with these specimens. Okay, so after that, it gives you some more information. The tissue is going to be kept dry and placed in a specimen container. So as I said, same specimen cup. This time, no preservative added, no formalin, no saline, nothing's going to be added. It tells you why. Formalin and normal saline is going to alter the freezing process. So what happens in pathology is they quick freeze it So then they can cut it into sections because that's what they do in pathology, but they're going to quick freeze it. So again, no formalin added to this one. Formalin is only for permanent sections because it fixes it into place. This one, we're freezing it. There's no reason to fix it into place. It's going to be fixed. It's going to be frozen completely. They're going to cut it into pieces from there. So again, frozen section, typically for cancer, but always so that we can get an immediate answer. So if you send a specimen to pathology frozen, you should be waiting on the answer. Okay, that actually brings me to the next part. So look at your last sentence. The pathologist reports directly and discreetly to the surgeon in the OR. So patient's asleep, we'll do that scenario. Patient's asleep, they call and they might announce to the entire room, but talking to the surgeon, our specimen is whatever the diagnosis is, or they might just say benign or malignant. Typically, they're going to say exactly what it is. So for instance, when I worked on brain tumors, when we would send off a frozen, we would hear back immediately if it was a glioblastoma, if it was a meningioma, what type of tumor it was. So we knew just by hearing the name whether that was benign or malignant. So let me add what it says in here too. If the patient is awake. So as you know, we do many surgeries where the patient is awake. Unfortunately, I'm going to go with my same example, craniotomies. So some craniotomies are done awake to preserve the patient's functions, their hand and eye coordination and speech and motor functions, different things like that. So we have the patient awake. So the nurse has to remember, the circulator has to remember when they answer the phone from pathology to not hit that speaker button, hear the report, document that, and then come over to the surgeon and make sure the patient cannot hear what that diagnosis is. Because it's the doctor's job to give that patient the diagnosis and be able to explain it in full detail. I would not want to be awake having a surgery and then hear over the speakerphone, your patient has a glioblastoma. That is not what you want to hear in the middle of your surgery. It's hard enough to keep patients calm during awake surgery. So that part is very important. If the patient is awake, make sure it's very discreet when you are talking about the pathology. Okay, so that is everything about frozen and permanent sections. All you have to add is fresh. So the difference with fresh specimens, they're not going to freeze it. That is your difference. So still no formalin, no fixative. They're just not going to freeze it. They're still going to send it off right away and try to get results faster for you, but it is fresh. So your only one that is completely different, special, is that permanent one that is fixed in formalin. I hope you understand that's part of your incisional and excisional biopsies, because it's very important to understand that as a script tech. And I will here in just a minute go over how to pass off a specimen properly so that there is no miscommunication with specimens. Too important. Okay, so this next section actually jumps over to specimen marking. So I'm going to keep talking about centesis. So ignore the picture for just a moment and look at centesis and fluid analysis. So I want you to know what centesis is. I want you to know what we're removing some fluid. It's usually diagnostic, but there's therapeutic purposes for it. I just want you to read through these terms and know what it means. You took medical terminology, you should know what these terms are. Example, paracentesis. It says removal of ascites, that is accurate, from the peritoneal cavity. So it's telling you where it is in the word of the name. So let's do it again, thoracentesis. I'd like you to pay more attention to this one than the others. Thoracentesis is done more often. Placement of a needle into the pleural space. So even though it's in the pleural space, thoro is telling you it's in the thoracic cavity. So thoracentesis, you should read it and know we are needle aspirating something out of the thoracic cavity. From there, you can learn and critical think that it's going to be in the pleural space. And now you have learned today that this is going to be to analyze the pleural effusion. So if a patient has pleural effusion, they're going to get a thoracentesis. So if you've ever known somebody who's had fluid in that pleural space, so around their lung, that's normally how doctors word it. You have fluid surrounding your lung. They're going to go in with a needle and aspirate that, and that's going to be called thoracentesis. Next one, amniocentesis, is in the amniotic sac for pregnancy sampling. After that, pericardiocentesis. You know your med terms, you know that word. So pericardial sac is what it's talking about, and it's inserting your needle into that pericardial sac, usually for the same reason. Fluid that shouldn't be there is there, and we need to remove that and get that out of the way. Okay, now we can look at spinal tap. So spinal tap, you will add some notes, but it's basically a lumbar puncture. I shouldn't say basically a lumbar puncture. They're going to use both terms interchangeably. So spinal tap, lumbar puncture, same thing, just two names like we love to do in surgery. So lumbar puncture, more commonly known as a spinal tap, involves needle aspiration of CSF. If you don't have that term memorized, CSF, you should, cerebrospinal fluid. So they can look at that CSF and make a lot of diagnosis off of it. So observing that fluid for diagnosis is reserved until the CSF has undergone laboratory analysis. So I'm pointing that out because on a lumbar puncture, when they pull back and that fluid starts coming into the syringe, they might look at it, and if it's cloudy or bloody, they might be telling you their own diagnosis. This is what I think it is. Nothing is definitive until we hear from pathology. They're going to send it to pathology and get a more involved analysis. Okay, so here's the note I want you to add. Next to spinal tap, aka lumbar puncture, they're going to do this for meningitis, encephalitis, many other things, but I'll start with those two, for meningitis and encephalitis. So two different options for when we're going to do a spinal tap to get a diagnosis for a patient. So basically that spinal tap will tell them whether they have meningitis or encephalitis. Okay, after that, it talks about endoscopy. I don't know how much you learned about endoscopy and micro and sterilization, but I will be sure to go over that a little bit more in general surgery, because as you can see in your book, it doesn't go into a lot of detail, but don't worry, I will. So endoscopy, I talked about this in the last chapter, but I want you to write a little note for yourself. So endoscopy, some people call it the endo suite. It's usually separate from all the other operating rooms. One of the hospitals I worked at, it was on a different floor, so they knew it was separate. But we're still doing surgery in there. We're doing invasive surgery. A lot of the times it's just diagnostic. Sometimes we're taking biopsies and things like that, but it's just endoscopy. So we're going to be doing upper and lower endoscopy. So that's the note I want you to make. Upper and a lower endoscopy. Your upper endoscopy is called the EGD. EGD. You should already know this term, but I'll get to say it for you. Esophagoduodenoscopy. EGD. After that, you can do a lower endoscopy, and that is used with a colonoscope. So we're going to do a colonoscopy. Colonoscopy. So one more time, lower endoscopy is a colonoscopy. You're going to be looking at the colon and all the way down. An upper endoscopy, let me break it down a little smaller for you. Esophagogastroduodenoscopy. One more time for you, if you want to replay over and over again. Esophagogastroduodenoscopy. So it's telling you every anatomy we hit. It hits your esophagus, it hits your stomach, it hits your duodenum or duodenum, depending on who is pronouncing the word. So that's a little heads up for you. That's not something that's going to be on your exam this week. That's something a little heads up for you, so you understand the full scope of the OR, and we're going to be talking about it in general surgery next week. After that, it goes back to our care and handling of specimens, and now you can look at the picture on my slideshow. So let's talk about loss of specimen. So loss of specimen can have devastating effects on the patient. It could cause the patient to have a second procedure. That means you lost the specimen. They have to go back in and get another specimen. So another procedure, that's heartache on your patient and a lot of money. It could also delay post-operative treatment. And more importantly, this is what I get for recording at school. So let me go back to where I was before the intercom came over. So it might delay post-operative treatment if you lose that specimen. More importantly, if all the tissue was removed and lost, a definitive plan of treatment may be impossible. So I have been at work when something like this happened. They took an excisional biopsy. They got the entire tumor. The specimen was placed on the back table where it belongs. The scrub tech forgot to pass it off to the circulator. So the specimen got thrown in the trash. Unfortunately, this is not an uncommon thing. So the specimen got thrown in the trash because this was a cancer case and there was no other tumor to take. There's no cancer treatment for that patient. So I don't know how you can go home and sleep well at night knowing you threw somebody's probable cancer treatment in the trash. So your job is very important. Keeping track of that specimen should be one of your number one priorities. You have a lot of number one priorities as a scrub tech. You got to keep track of the count, keep track of the specimen, make sure nobody causes any burns or sticks. You are in control of that sterile field, but really want to hit on the importance of not losing a specimen, especially with cancer cases, because that is what I have seen. So the surgeon has nothing to go off of. There is no pathology now. So they can try to guess on how to treat it, but they are the ones that have to go tell that patient, we lost your specimen. You're not going to have to go talk to the patient and explain to them what you did. The doctor has taken on the responsibility of your mistake, unfortunately. So they have to go tell the patient that they lost the specimen and they're not sure what to do with their cancer treatment. So what you're going to do is read all of this very carefully and have it in your mind that I'm never going to lose a specimen. That's my priority. So you will remember this and not lose a specimen from my scary story. So 393 I'm still on, but now I'm going to go to the right side top of the page. So correct labeling. Specimens must be labeled correctly, and you could probably learn that from my story because the same thing could happen with a mislabeled specimen. So you will get a sterile marker and labels inside your pack. Some of these are pre-written, some of them are blank, but you always have a skin marker and labels in your packs so that you can always label your specimens just like you're going to label your medications. Very important. Next to this, I want you to put 3 questions. So 3 questions, and this is going to be every time you pass off a specimen. So let's say you've already labeled it correctly. You're still going to ask questions. So let's say this is an appendectomy. The surgeon gives me, here's my appendix. The surgeon gives me the appendix. I put it in the specimen cup. Before I pass it off to my circulator without contaminating, I'm going to ask 3 questions. What is it? How do you want it sent? And may I pass it off the field now? So, what is it? Even if you already know what it is, you're going to ask the surgeon, what is this? Now, after you become comfortable with for a while, you've been working with the same surgeon for years, you might just confirm, this is an appendix, yes. You could do something like that. You don't get to do that first starting out, and especially as a student. So what is it is number 1 question. What is it? The surgeon says, appendix. How do you want it sent? You know the 3 options are permanent, fresh, frozen. So they say, let's say permanent. Permanent. Okay, may I pass it off the field now? So you're asking this 3rd question because some surgeons like to take the specimen and cut it in half on the back table and look at it themselves. You know, sometimes it may not be a frozen specimen where they're going to treat it a certain way in pathology. They want to cut it open and look at it themselves. They just took the tumor out. They want to see it. So Sometimes they will do that on your back table, and that's why you're gonna ask, may I pass it off the field now? Now, when it's a frozen specimen, the answer is always gonna be, yes, get it off the field now, we want the results. So be ready for that, but 3 questions, I will review that with you. What is it? How do you want it sent? May I pass it off the field? So 3 questions you're gonna ask every time you are using or dealing with a specimen during a case. So we learned that in the lab. You guys are getting extra and you're learning it in my lecture also. After that, specimen markings. So specimen markings, there's lots of options. So that's what the slide is for. This one is to show you ink. I loved it when they used ink because sometimes they have different colors. So they could do anterior red, posterior green, lateral purple, medial orange, something like that. So they do all different colors, so then when they get it in pathology, they don't have to worry about the orientation. It's in the right orientation. They know exactly how this was setting inside the body. Because if you don't denote the margins in some way, it's just a clump of tissue. So if one side of it is cancer and the rest of it was benign, the surgeon doesn't know where to go back and make more cuts. They have to be very specific. So they're gonna mark this specimen so that if it comes back and there's a positive margin, which means cancer, malignancy, on, let's say the backside, the posterior side of that tumor, that's the only area they need to go back and take more tissue that could be cancerous. You don't want them to go take a bunch of tissue for no reason, right? So that's why they're gonna denote the margins. So tissue margins, know what that is, the edges of the tissues. Some people like to do an extra margin, so they'll take the specimen and then they go a little ½ inch all the way around where it was and take that too, because they think there might still be some cancer cells there. Let's get it out of there so it can't spread any further. So those are tissue margins. You're seeing the ink option that talks about in your book where it says painting. Another one I want you to pay attention to is the suture marker. So that means they can use the skin marker to mark your specimen. They can also use suture. That is the most common way. So they're gonna get a suture, they're gonna mark, let's say 4 different sides, and they're gonna denote it in a different way. They can use different color of suture, or they can cut the strings different lengths. So example, how we sent our breast tissue specimens. It would say, long stitch lateral, short stitch superior, et cetera, all the way through. And we sent a little key with our specimen denoting what stitch equals what. But in general, if the surgeon does it the same way every time, it's easy for you to remember, like short stitch superior. That's easy to remember. Find on specimen marking where it talks about clear, no malignancy. So after the pathologist examines that specimen under the microscope, they're going to verify the margins are clear with no malignancy. So if your margins are positive, they're going to take more tissue out. If they are negative or clear, there's no malignancy. And everybody in the room goes, yay, no malignancy every time. Okay, so after that, reading about your specimen markings, let's look at foreign bodies as evidence. Foreign bodies as evidence. So care of bullets must prevent the alteration of forensic markings. Well, for you, I have lots of experience with this one, unfortunately. So when they take bullets out, they want to make sure nothing metal clamps onto it. So if a surgeon asks for a clamp to grab a bullet, that is incorrect. They should be using a forceps that maybe has holes on the side to where it's not going to clamp metal to metal, no scraping or clamping is happening. We want to gently get that bullet out so we are not messing with forensic evidence. So where it says evidence procedure at the very end of that paragraph where it says foreign bodies as evidence, I want you to put handles bullets. Our evidence procedure is how we're going to handle bullets. So you have to actually sign some paperwork yourself if you are ending up in this situation, because you're kind of part of the chain. You were around this forensic evidence and they have to track who was around that evidence all the way until it gets to the evidence locker. So you have to know that you're gonna have to sign some paperwork saying, yes, I handled this bullet. And so I know that at any time, if they're going through an old case, they could call me up and ask me about that. So you are part of the chain of custody with this forensic evidence for a very short amount of time. So if you handle any bullets, you will be signing some paperwork after that procedure. And again, this is to work with law enforcement officials so we can keep track of not only specimen, but chain of evidence. Other foreign bodies, there's other examples, lots of things with children, a lot of extracted teeth swallowing, but there's more examples of foreign bodies and we do remove those. Specimen containers, let's talk about that. So you saw a normal specimen cup. There are different sizes for different size specimens, and sometimes the specimen is just too big, so you might put it in your kidney basin and pass it off to your circulator like that. So they won't contaminate, they can just grab the other end and then put it in a container that has a lid on it, and they can do their charting and labeling from there. So pick your container based on the size of your specimen. Then that brings me to TELFA. So now next to TELFA, I want you to put GYN next to it. This is just one example that they use TELFA in. There's lots of other surgeries where we're going to use TELFA, but GYN, especially DNCs, we always put our specimens on a TELFA pad. So a TELFA, as you've already learned, I know, is a dressing, but we can use this to put specimens on. I'm showing it to you in the light because it is shiny. It doesn't look like other dressings. So it's just a white dressing, but it's nice and shiny. So something small like a specimen, it's not going to stick to this like a 4x4 or a Raytex, something that's woven. It's not going to stick in there. We're not going to lose the specimen. It's going to lay gently on top of this shiny material. So your book says that you can fold it up and put it in a towel. What would be smarter is to put it in your specimen cup where it belongs and pass it off that way. So please make that note. We're not going to be folding it up in a towel. We're going to be putting it in a specimen cup. But it's telling you all small specimens, you're going to be putting it on a TELFA. And there's specific cases like what I gave you, a DNC, where you're always going to use a TELFA pad regardless of how small it is. And that's just because it's not going to adhere or stick to it. It's nice and shiny. It's going to lay on top. Easy for pathology to use. Okay. After that, look at calculi. This is a review for you. Calculi kidney stones are always sent dry to pathology, never in formalin. On page 394 at the very top, we're almost to the end here, amputated limbs. This is very odd because it's such a big specimen. So especially if you do a above the knee amputation, common procedure, you're gonna have to drop that leg into a bag without contaminating. I would always try to pick it up at the foot actually and drop it into the bag and kind of lean my face away because there's going to be some blood splatter happening. The difficult part is not contaminating during that case. Some nurses, like, that's only one example I can think of, like to leave the big specimen like that, a leg, on the table. So then when we're done, we can bag it up and not have to worry about contaminations happening. But you will be doing amputations, and you need to know that these will be carefully bagged and wrapped for transfer. Okay, last one, orthopedic implants and hardware. So yes, some patients want their hardware back, first of all, but we're always gonna send it to pathology. They have found pus and infection inside of these implants before, and that might help understand what the patient's issue was with the implant. So know that they're going to send that to pathology. On a side note, not for your exam, know that some patients, they pay a lot of money for that hardware, right? So they want it back. So sometimes when you do a removal of hardware, common procedure, you remove the hardware, you might have to clean it and sterilize it and put it in some sort of a package so you can give it back to your patient. And they have every right to ask for that because they paid for that hardware. So it's possible they could ask for it back. Maybe they set it on their mantle, I'm not sure. But I hope you understood, more importantly, specimens from this slideshow. So it talked about some other things, but the point I want you to get, specimens are so important. You cannot make a mistake on specimens. So make sure you are double checking and make sure you are repeating. That's the easiest way to make a mistake, is bad communication. Communication is so important in the operating room. And as you can see, it affects patients' lives. So the story I gave you of the mistake that happened with the specimen getting thrown away, that could have been fixed with better communication. The nurse could have reminded the scrub tech, hey, don't forget to give me that specimen. The scrub tech could have reminded the nurse, hey, I need to give you this specimen. It's only the two of you that need to be focused on the specimen. The surgeon is focused on doing surgery. The anesthesia provider is focused on keeping your patient asleep. That's your responsibility. So you have a big responsibility. I hope you take it seriously as I do, and I hope you learned a lot from the little short portion of this lecture to end diagnostic and minimally invasive surgeries. So I hope you learned something, and if you have any questions, feel free to ask me. You can send me a Facebook message or you can email me, and both of those links are on my course connection. So let me know if you have any other questions. Thanks, guys.